All right, so last time we left off talking about the bones and bony landmarks of the shoulder girdle, and then where we really finished was talking about arthrokinematics. And so remember that arthrokinematics are tied into osteokinematics. Osteokinematics, so in terms of terminology, osteo means bone, kinematics deals with movement. So osteokinematics are bone movement, and so remember that osteokinematic motions are those readily observable gross motions where one bone is moving on another. So things like glenohumeral flexion or extension or abduction, things that I can see you do, they're pretty obvious motions. Those are osteokinematic motions. But in order for normal osteokinematic motion to occur, we have to get arthrokinematics, or have to have arthrokinematics. And so those are rolls, slides, and spins between the two bones inside of the joint that allows for the osteokinematic motion to occur. So remember, there's some disruption of the arthrokinematics. If one bone can't slide on another, then that's going to limit the osteokinematic motion, so that their range of motion will be altered. So that's where we left off last time. So we're going to pick up this time talking about the articulations of the shoulder girdle. And so articulations and joints are pretty much the same thing. They are essentially synonymous, and I'll use them that way with the exception of the bottom one on there that you see, the scapulothoracic articulation. So when we talk about joints in an anatomical sense, we've got a place where at least two bones interact with each other to produce movement most of the time. Now, not all joints are mobile, but the ones that we're going to spend most of our time on, those are going to be your mobile joints. So in the case of an articulation or a joint, you've got two bones interacting most of the time to produce movement. There are certain joints where you've got more than one bone interacting. So for example, in the foot or in the hand, there will be multiple bones that interact to produce motion. But most of the ones that we're going to spend our time talking about, there's only two of them. So the first one on there is the sternoclavicular joint. And so you can see then that because joints are typically two bones interacting, oftentimes the name of the joint will be the two bones that interact. So the sternoclavicular joint then is formed by the interaction of the sternal end of the clavicle. Remember, that's the more rounded of the two ends. And then the clavicular notch here on the manubrium of the sternum. So essentially then what you've got is the interaction between the clavicle and the sternum, but there you can break it down a little bit more in depth. But the sternoclavicular joint then, because this is on the lab 1 sheet, in terms of bones that articulate, so you got the sternal end of the clavicle, and then you've got the sternum there that's articulating with it. So that's your sternoclavicular joint, and we'll talk a little bit more about each of these. But then you've got the acromioclavicular joint. So remember that your tip of the shoulder, this flat part out here, that's part of the scapula. So remember that that is called the acromion. And then that's going to interact with the acromial end here of the clavicle. So then you get the acromioclavicular joint, is that interaction. And then we've got the glenohumeral joint, which is the primary joint of the shoulder. So that's formed by the interaction of the glenoid cavity, which remember is part of the scapula. So it's one of the landmarks that we covered on the scapula. So you got your glenoid cavity and then the humeral head. And so then that makes it the glenohumeral joint, again, the primary joint of the shoulder. And the last one on there, the scapulothoracic articulation, describes the interaction of the scapula with the chest wall. So remember that we talked about the thoracic cavity, that's everything inside of your rib cage. So your thorax is basically your rib cage. So the scapulothoracic articulation then describes the interaction between the scapula and the rib cage. However, I labeled it specifically as an articulation, and some anatomy books do this to indicate that you don't have one bone directly touching another. So for example, in the glenohumeral joint, you have direct contact between the humeral head and the glenoid, but we don't have that in the scapulothoracic articulation because there are two muscles that sit between the scapula and the thoracic cavity. So you've got subscapularis, one of the rotator cuff muscles that lines essentially the front side or the anterior aspect of the scapula. And then you've also got the serratus anterior muscle, which is one of the scapular muscles that we'll talk about probably on Monday of next week. So those are the articulations of the shoulder girdle. So one of the things to be aware of when we talk about the shoulder is that for normal glenohumeral motion to occur, like throughout its full pain-free range of motion. In order for that normal glenohumeral motion to occur, we have to get scapulothoracic motion. So sometimes later in the slides, you'll see the scapulothoracic articulation, abbreviated SC. So I want you to know 6 scapulothoracic motions, and then there's 2 more at the bottom that we'll talk about that I won't ask you questions about, but being aware that they occur is important from an injury standpoint. So the motions that I want you to know at the scapulothoracic articulation, there are 3 pairs of them, so 6 total. So you've got elevation and depression. And you can see on the slideshow here, if we elevate our scapulas, what's going to happen there, that's that shrugging or the I don't know motion. That's scapular elevation, because if you elevate something, you bring it up. And so if you elevate your scapulas, you bring them straight up toward your head. So if we can elevate something, then we can depress it. So if you're depressed, you're down or feeling low, right? And then, so scapular depression is bringing your scapulas down. And so we can see that as a return from elevation, or you can see that in terms of where that actually occurs during your activities of daily living, the things that you do all day long. If you go and like grab the arms of a chair and push yourself out of the chair, you're going to get scapular depression along with some glenohumeral motion that's going to occur there. So scapular depression, bringing the scapulas down. Scapular protraction is actually down here. So you can see there that different books use slightly different terminology. So some books use abduction to refer to protraction of the scapulas. I'm going to use protraction because there's a glenohumeral motion that's abduction. So to keep you from confusing the two, I'm going to use protraction when I'm referring to scapular motion. So scapular protraction, that is, I often describe it as bad posture. So if you slide your scapulas straight forward, kind of slouch over, that's scapular protraction. So it's bringing the scapula, sliding them anteriorly. Scapular retraction then is the opposite. And so you can see at the top right, it's pinching your scapulas together. So again, sometimes I would refer to this as good posture. So if you bring your scapulas together, if you kind of poke your chest out, that's going to be scapular retraction. So you do that at the end of like a rowing motion, that's scapular retraction. And then in the middle of the rowing motion, so when you reach all the way forward, you're going to get some scapular protraction there. So protraction, scapula slide forward, retraction, scapula slide posteriorly. And then upward and downward rotation. So both of those are going to occur. Upward rotation is going to occur with glenohumeral or shoulder abduction, so bringing your arm away from the midline. In order for that to occur, again, through that full pain-free range of motion without pain in your shoulder, you have to get good upward rotation of the scapula, and that's on the bottom row, this middle one. So in order to determine upward rotation, I mentioned this previously, one of the things that we'll do is to observe that inferior angle of the scapula. So remember, that's this thing right here. So we'll watch the inferior angle of the scapula, and so if we go from a normal anatomical position and we lift our arm up over our head, which again is abduction at the glenohumeral joint, that abduction at the glenohumeral joint is going to occur with upward rotation of the scapula. So that inferior angle is going to rotate up and out. And then downward rotation is just the opposite motion. So that's where that inferior angle of the scapula rotates down and in. And so we'll get downward rotation with adduction of the glenohumeral joint. So when you bring your arm back down to your side, when you come back to anatomical position from having your arms overhead, that's when you're going to get downward rotation. We also see that, so you see both upward and downward rotation to the greatest extent with adduction at the glenohumeral joint, but you also get some of both of those with flexion. So when you lift your arm straight forward overhead from anatomical position, you'll get some upward rotation of the scapula. And then when you extend your arm, so when you bring your arm back down to anatomical position, you'll get some downward rotation again. The bottom two on here, the anterior and posterior tilts. So you get those two with hyperflexion and hyperextension at the glenohumeral joint. So if you flex at the glenohumeral joint, remember that's going from anatomical position, taking your arm straight forward, right? So keeping your palm in that supinated position where your palm's facing anteriorly, coming straight up overhead, that's going to be flexion. And if you reach up overhead as high as you possibly can, so you can probably go a little bit past 180 in terms of hyperflexion at the glenohumeral joint, you're going to get a posterior tilt of the scapula. So in terms of determining tilt of the scapula, now we're actually looking at that superior angle. So I'll stay on his right side. So if he hyperflexes his shoulder, if he reaches up over his head as far as he possibly can, that superior angle of the scapula is going to tilt backwards, going to tilt posteriorly a little bit. And then if we go the other direction, so if he brings his arm down to his side, back to anatomical position, and then extends his arm even more, that's going to be an anterior tilt of the scapula. So that superior angle is going to tilt forward a little bit, so tilt anteriorly, so that's an anterior tilt. And then internal external rotation, so those occur typically with internal external rotation in the glenohumeral joint on the shoulder. So internal rotation of the scapula is going to occur if you fully internally rotate your arm. So internal rotation of the glenohumeral joint is when you take the anterior part of your humerus and rotate it towards your midline. So if you have somebody take the back of their hand and put it on their low back, so there's pretty much as far in internal rotation of the glenohumeral joint as they can get. You're also then going to get a little bit of internal rotation of the scapula, and so you'll see that oftentimes, depends on their scapular stability, but oftentimes that medial border of the scapula is going to pop off the chest wall a little bit, and so that's full internal rotation of both the glenohumeral joint and the scapula. And then external rotation, if you externally rotate at the glenohumeral joint, you're going to get where the medial border of that scapula is going to press into the thoracic, or the thoracic wall, I guess is a way of saying it. So it's going to press in or press anteriorly, and so then that's external rotation of the scapula. So like I said, I want you to know these top 6. You can ignore the tilts and the internal external rotation. Those will just come up, like I said, when we talk about injuries. All right. So that was scapular motion, or scapulothoracic motion, which is, like I said, abbreviated ST on the slideshow later. Now we're talking about glenohumeral motion. So now we're talking about the actual shoulder joint. So you got 6 motions at the glenohumeral joint that I want you to be aware of. And those, again, 3 pairs. So you've got flexion and extension. And you can see here, taken from one of the anatomy texts I use, might be this textbook, or it might be another. I don't remember where I got this one. But anyway, coming from anatomical position, although her hand is flipped over, she's in pronation, but bringing her arm straight forward, that's glenohumeral flexion. And then if we go the other way, returning from flexion back to anatomical position, that's extension. And so you can see here that some books refer to anything past the body. So she brings her arm from being at her side backwards. A lot of books refer to that as hyperextension. I don't use that term much. I basically just use extension. So flexion is forward, if that helps, and then extension is returning from flexion or coming back this way, as she's doing all the way on the picture, or on the picture all the way on the right. And then we've got abduction and adduction. So if you abduct at the glenohumeral joint, you're going to, basically the way that I remember it, if you abduct something, you take it away. And so if you abduct at the glenohumeral joint, you take your arm away from the body. So that is lifting your arm straight out to the side. So that's lateral raises if you're in the weight room. And then adduction is adding the arm back to the body. So you're returning back to anatomical position. And then the last 2 on there are internal external rotation, which are not on my anatomical pictures here. But remember that, like I said, internal rotation, front of the humerus rotates toward the midline. External rotation, front of the humerus rotates away from the midline. So you see both internal and external rotation during the throwing motion. So when you're at the end of the wind-up, when your arm is all the way back as far as it's going to go during the throwing motion, that's maximum external rotation, and that's paired with abduction. And then as you release the ball, or finish your serve, whichever thing you're doing, then your arm is moving into internal rotation. So the other things on here, on the lab, we talked about planes and axes. So remember that both flexion and extension occur in the sagittal plane and around or about the x-axis. AB adduction, those are going to occur in the frontal plane and around or about the Z or AP axis. And then internal external rotation are going to occur in the transverse plane or horizontal plane and around or about the Y axis. So that should help you fill out that lab sheet. All right, so let's talk about particular joints. So we're going to talk about the sternoclavicular joint first. So what I'm going to do here is I am going to, you can see my notes there, I'm going to use the anatomy app to do that. So again, I'm always going to use his right side. So remember that his sternoclavicular joint is the interaction between the sternal end of the clavicle and then the sternum itself. So the sternoclavicular joint, I'm going to zoom in a little bit. If I can get it to do that. There we go. So there's his right sternoclavicular joint. So one of the things to know about it, not that, is that the sternoclavicular joint is the only true joint that connects the arm to the axial skeleton. What is the axial skeleton? That is your skull, your spine here, your ribs, and your pelvis. So if I zoom out some, I assume you all know what your pelvis is, but in case you don't. So this is the pelvis, right? So your axial skeleton then, skull, spine, ribs, and pelvis. So the only true bony connection between all of your arm and the axial skeleton is this little joint right here. Because remember, our scapulothoracic articulation, there's no bone-to-bone connection there because of the layers of muscle between the scapula and the thoracic wall. So the sternoclavicular joint then is the only true bone-to-bone connection. All right, so because of that, that has to be a pretty stable joint. And so if we add some layers to him, so we're going to add some layers of connective tissue here, till eventually, there we go. So now we've added layers to the sternoclavicular joint or SC joint. So one of the things we'll talk about, so joints have their own chapter later on, it's chapter 8, but I'll tell you some of the stuff about joints now. There's a few things that are important to know. So ligaments connect bones to bones. So for example, this is a ligament over here. So that's the coracoacromial ligament. So they connect bones to bones. And then tendons connect muscles to bones. So tendons are muscles to bones. And if you injure a ligament, which connects bones to bones, then that's called a spurane, SP. And if you injure a tendon or a muscle belly, that's called a styrane, ST. All right. One other thing before I move on too much. So the joints that we're going to talk about in terms of where motion occurs typically are synovial joints. They're joints that have a 2-layer capsule. And so if I actually back off and subtract a little bit of connective tissue here, I'm going to look at his glenohumeral joint. I'm going to look over here at his shoulder. So this inner layer of the capsule is called the synovial membrane. And the synovial membrane, what it does is secretes a lubricating fluid that helps those two bones slide on each other. So that's the inner layer of the membrane, or the inner layer of the joint capsule. And then if we add some more layers, you'll get this outer fibrous layer. So that's the second layer of the joint capsule. So this is collagen, really dense collagen that goes in a bunch of different directions and helps stabilize the joint, helps keep those two bones from sliding apart. So that's that outer layer of the joint capsule. That's the fibrous layer. All right, so back to our sternoclavicular joint. We'll add that back in. All right, so again, because that's the only bone-to-bone connection between the arm and the axial skeleton, it has to be a stable joint. And so to ensure joint stability there's a few things. There's the congruity of the joint shape itself. So this one is referred to as a saddle joint. I'm actually going to switch back to my slideshow. I want to show you a picture. So this is, again, the right sternoclavicular joint. So it's called a saddle joint because there are the surfaces are both concave and convex on different aspects. So remember when we talked about arthrokinematics, you've got one shape or one joint surface typically that's concave, that caves in on itself, and you've got another joint surface that is convex, that curves out. So in the case of the glenohumeral joint, you've got the concave surface is the glenoid cavity, and then the convex surface is the humeral head. In the sternoclavicular joint, however, you have a concave surface medial to lateral and a convex surface anterior to posterior. And why that matters is that allows for at least 2 planes of movement. So the most famous, if you will, saddle joint in the body is in your thumb. It's in the carpometacarpal joint. And so because of that particular saddle-shaped joint, that allows you to extend the thumb, which is doing a thumbs up motion. It also allows you to flex your thumb, which is bringing your thumb toward your hand, and to abduct the thumb, which is bringing your thumb straight forward from anatomical position, and then adduct the thumb, which is bringing it back. So that allows for 2 planes of motion there. And so in the case of the sternoclavicular joint, it's going to allow us to slide the clavicle, or rotate the clavicle anteriorly, rotate the clavicle posteriorly, which we're going to do in protraction or retraction. It allows us to rotate the clavicle up and down, or superiorly and inferiorly, which we're going to do during both elevation and upward rotation. Then the clavicle is going to rotate up. And then it allows the clavicle to rotate back down, or inferiorly, when we engage in depression or downward rotation of the scapula. And then, because of the connective tissue arrangement, the clavicle is also able to rotate a little bit anteriorly and a little bit posteriorly, which we're going to get with those anterior and posterior tilts of the scapula. So the clavicle, or the sternoclavicular joint, actually moves in all 3 planes. So again, it's going to get that anterior-posterior rotation, upward and downward rotation, and then it's going to rotate forward and backwards. So again, you can see there that it's got a thick capsule, and then there are 4 ligaments, again, bone-to-bone connections, that help secure the sternoclavicular joint. So the first one here is the anterior sternoclavicular ligament, which you can see I've highlighted. And then you've also got a posterior sternoclavicular ligament. So to get to the posterior one, I'm going to rotate him down a little bit. And I'm actually just going to use his left side because it makes life a little bit easier. This one is his posterior sternoclavicular ligament there. So you've got those 2, so one on the front and one on the back, that help secure the joint. And then you also have, slide him down, interclavicular ligaments. So inter is between, so interclavicular, you've got ligaments that run then between the clavicles. And so your interclavicular ligaments, there's one side right there. So there's a right and a left. And then if I add a little bit more connective tissue, so there we go, and one more layer, then we'll get the costoclavicular ligament, which you can see I've highlighted now. So another thing that I should point out, so this white stuff that I brought in with the previous layer, I think with layer 5, that is the costal cartilage. So anything costal means ribs, and so the costal cartilage is a type of hyaline cartilage that adjoins each rib to the sternum. So there's not a direct bone-to-bone connection there. There's actually cartilage that sits between the ribs and the sternum. So then the costoclavicular ligament is going to originate here on that costal cartilage of the first rib. And one of the muscles we'll talk about, subclavius, also will originate or arise from that costal cartilage. So 4 good strong ligaments that help stabilize the sternoclavicular joint, so that keeps it from dislocating. In the sternoclavicular joint, another thing to know about it, it's a surprisingly important little joint. So every time you, well, not exactly every time, I should back up a little bit, but so go to anatomical position where you're standing there with your arms at your sides. Anything below 30 degrees, whether that's 30 degrees of abduction or 30 degrees of flexion, you don't have to move your scapula. But if you move your arm past 30 degrees of abduction or flexion or extension, then you have to get some scapular motion that accompanies that. And so when the scapula moves, the sternoclavicular joint has to move as well. And so one of the ways that you can do that on yourself, if you go to your neck and you'll find the sternal end of your clavicle. It's pretty obvious. It's a big knob there on your neck. So there's obviously one on the left and one on the right. So just pick one. I'm on my right clavicle. Go just underneath that. So go inferiorly a little bit and you'll feel a really obvious drop off. So that's your sternoclavicular joint. And then if you stay there with your fingers on your sternoclavicular joint, if you protract your scapula, so slide them forward, you'll feel your SC joint move a little bit. So you'll feel that anterior rotation of, or forward rotation, if you will, of the clavicle. And then if you protract your scapula, so if you bring them back toward the midline, you'll feel the clavicle rotate back. And then if you shrug, so do scapular elevation, you'll feel the clavicle rotate up and then depress them, right? And then if you reach all the way overhead, you'll feel the clavicle roll a little bit. If you reach all the way behind your back, you feel the clavicle roll a little bit there too. So any movement past 30 degrees, you're going to have to get some scapular motion. And in order to get scapular motion, we also have to get motion at the sternoclavicular joint. It's a surprisingly important little joint. All right. So from the sternoclavicular joint then, we'll work laterally a little bit, and I'll click off that ligament. So then we're going to go out to the acromioclavicular joint. So the acromioclavicular joint, we take off some layers of connective tissue. There we go. Whoop, one. There we go. All right. So again, that's formed by the acromion, that tip of the shoulder here, so this flat part of the scapula, and the acromial end of the clavicle. So that's your acromioclavicular joint here. So that's a joint that it has a joint capsule as well. So there's our synovial membrane that I just added, and then we can add the fibrous layer to our capsule there. There we go. And so in the case of the acromioclavicular joint, the joint capsule is referred to as the acromioclavicular or AC ligament. And so different textbooks actually separate it into superior and inferior portions, but neither the anatomy app nor this textbook does. So we'll just call it the AC ligament and know that I'm referring to the joint capsule. So in addition to the acromioclavicular joint being secured by the AC ligament, you've also got two ligaments here. Here's one and here's the other one that hold the clavicle to the coracoid process. Remember, the coracoid process is this thing, this little bird beak. And so those two ligaments collectively are referred to as the coracoclavicular ligament because they run from the coracoid process to the clavicle. But there are two of them. So there's the trapezoid ligament, which is the one I've highlighted here, which is the more lateral of the two. And then there is the conoid ligament, which is the one I've highlighted now. So the trapezoid and the conoid ligaments collectively make up the coracoclavicular ligament. And again, they're going to hold the clavicle close to the coracoid process. So they help reinforce the AC joint. So just like the SC joint, the AC joint is going to permit motion of the scapula. So I'm going to go back here to the slideshow. And I'm going to show you kind of what that looks like. So as you can see from the little arrows here, so every time we rotate the scapula up, so every time we engage in upward rotation, we're going to have to get some motion at the AC joint. So in the case of upward rotation, you're going to get a little bit of a roll and then a downward slide at the AC joint. And so those are those arthrokinematic motions we talked about. And then same thing, if you come back down, so if you bring your arm back down to the side, you'll get some sliding at the AC joint as well. And then if we get, let's go with tilting. So if we do anterior and posterior tilting. So again, if you reach all the way overhead and you hyperflex at the shoulder, you're going to get a posterior tilt of the scapula. And so then you're actually going to get a little bit of a spin there at the AC joint. So again, the AC joint, surprisingly important. It's a joint that normal motion at the AC joint allows for scapular motion, and scapular motion allows for glenohumeral motion. So there's kind of this links in a chain to allow for normal arm movement. We have to get motion at the SC joint, motion at the AC joint to allow for scapulothoracic motion, which then enables us to position the glenoid so I can get normal glenohumeral movement. So those all work together to allow for arm movement. So again, a surprisingly important little joint. So that one's easy to find too. If you go all the way out to your acromion, to the tip of the shoulder, you can work anteriorly, so forward and medially a little bit, and typically you'll feel a little drop off there at the acromial end of your clavicle. And so then you can do kind of a rowing motion, so you can extend your arm or you can flex your arm, and so you'll feel the AC joint spin underneath your finger a little bit. So you can see where AC motion fits into arm motion. All right, so I got a case study for you. And so the case study is, we're going to say that you're an athletic trainer, because I'm not very imaginative with my scenarios, but we're going to pretend you're an athletic trainer working at a football game. And so your quarterback gets tackled from the side, as happens to Jimmy Garoppolo here. Your quarterback gets tackled from the side, and he lands directly on the tip of his shoulder. And so after that happens, he gets up kind of slowly and he starts to jog over to the sideline. And you notice as he's coming over to the sideline that his arm is slightly abducted and it's not really moving. Like he's trying not to move it. He's grimacing in obvious pain. And it's bothering him so much, he goes ahead and takes a knee on the field after trying to jog to the sideline. So you go out there and talk to him and you ask him what happened. And he's going to tell you that when he was tackled, he heard and felt a pop in his shoulder. Okay. Well, can you tell me where it hurt? And he's going to tell you that the worst pain is on the top of his shoulder. But in addition to that, there's some pain kind of radiating up into his neck and then radiating down into his arm. Say, okay, it's a pretty good idea what might have happened here. And so let's go over to the sideline. Maybe I can take a closer look at it. So you get him over to the sideline, and then you have him sit down and take off his shoulder pads, which he's not going to be able to do without help. He can't raise his arm overhead. You have to kind of support his arm, help him get his shoulder pads off. And then once you get his shoulder pads and his shirt off, his arm, so in this case his right arm, looks like this. So you'll notice that there's an obvious deformity here. There's a bump on his right side that's not on his left side. And so the question is, what might have happened to our quarterback? What injury has he sustained? And the answer to that question is he has an AC sprain. So he has separated his shoulder. So a couple things there, which I highlighted in class and forgot to mention so far on this recording, is that when we talk about right and left, you're always talking about the right side of the patient or the left side of the patient. So for example, in this guy, so this is a right shoulder injury in that it's his right shoulder. I wouldn't say left because, you know, when I look at it, or us looking at this guy, that's on our left side. Everything you do, you orient to the patient's right or the patient's left. So this is a right shoulder injury, so he has an obvious deformity on his right side. Okay, and then the other thing is that, so again, this is an AC sprain. What he's done is he's separated, or he has stretched out the acromioclavicular ligament, which I'm mousing over here. So the little, I guess, lightning bolts indicate stretching out the acromioclavicular ligament. So that's a grade 1, or so they call it type 1, but type 1, grade 1 here mean the same thing. So that's a grade 1 AC sprain. You're going to get a lengthening or stretching of the acromioclavicular ligament. But if we apply even more force, so if we really drive down that acromion, which is what happened to our quarterback here, then you're going to get a tear or rupture of the acromioclavicular ligament, and then a stretching of the corticoclavicular ligaments. So that's a grade 2. And then a grade 3 is you tear the acromioclavicular ligament and tear the corticoclavicular ligaments as well. And so then their clavicle is going to pop up really big here, and you get what some textbooks refer to as a piano key sign, which is if you push down on their clavicle, it'll pop right back up, kind of like a piano key. Now that said, I've read that in multiple textbooks. I've never seen anybody actually do that to an athlete that had an AC sprain. I can't imagine why you would. But at any rate, the deformity is more obvious. The clavicle pops up more in a type 3 than it does in a type 2. With a type 2, you just get a little bit of a bump there. And so because you've still got that corticoclavicular ligament, it's still intact, but it's stretched out. So again, this is a shoulder separation. So I mentioned that because fantasy football season is coming up, so maybe one of your players, your running back or somebody, will be out with a shoulder separation, and oftentimes people think, oh, they dislocated their shoulder. Well, they didn't, because a shoulder dislocation is actually the glenohumeral joint, and we'll talk about that injury in a minute. So a separated shoulder is a spurane ligament damage to the AC joint, and not only the AC ligament, but also potentially to the corticoclavicular ligaments as well. All right. So scapulothoracic articulation, again, we've already talked about this. So it's not a true joint because there are two muscles that sit between the scapula and the thoracic wall. And movement of the scapulothoracic articulation is dependent upon normal movement of the sternoclavicular and acromioclavicular joints. So if I click to my last picture here, because I think this is the best one. So obviously this is upward rotation of the scapula here. So at the scapulothoracic articulation, the motion is upward rotation. But again, in order for that to occur, we had to get an upward rotation or elevation of the clavicle at the sternoclavicular joint. And then we had to get a little bit of a slide and spin here at the AC joint as well. So we have to have a motion at SC and AC to allow for scapulothoracic motion to occur. All right. So let's talk about the glenohumeral joint. So one of the things that I've mentioned about the glenohumeral joint is the relative size of the glenoid cavity versus the humeral head. So at any one time, the glenoid cavity is only going to cover up about a third of the humeral head. So there's not a lot of bony overlap. And there's some good and bad to that. The good to that is because there's not a lot of bony overlap, the shoulder is a really mobile joint. You've probably got, in terms of total range of motion, easily more than 180 degrees going from I said I wasn't going to say hyperextension, but I did. So going from hyperextension of the glenohumeral joint, where you're reaching back behind your body, all the way up overhead as high as you can reach, you've easily got more than 180 degrees of motion. And then similarly, more than 180 degrees or pretty close to that in terms of abduction at the shoulder. So you've got lots and lots of motion at the glenohumeral joint. That's good. It's a really mobile joint. But the trade-off is anytime you've got a really mobile joint, you've got an unstable joint. So because there's not a lot of bony overlap between the glenoid cavity and the humeral head, as there is, in the hip's the same type of joint, but there's a lot more overlap. There's a lot deeper socket to the hip, and so the hip's a much more stable joint, which is good because hip dislocations are pretty problematic. So the shoulder then, really mobile, not very stable, and so it's one of the more commonly dislocated joints, particularly in a sporting context. So depending on the sport we're talking about, maybe the second most commonly dislocated joint. So in a sport like football, the finger joints typically are pretty commonly dislocated, but behind the little joints of the fingers is usually the shoulder. So not a lot of stability there. Speaking of stability, so there's two types of stabilizers you can see there. There's static stabilizers and dynamic stabilizers. So a static stabilizer, I've got non-contractile in parentheses. So there I'm referring to the joint capsule, the ligaments, and then in this case the cartilage, the labrum of the shoulder. And we'll talk about each of those in a second. But your static stabilizers, particularly the ligaments and the joint capsules, determined the end range of motion of a joint. So for example, if I were to have you lie on a table supine, so face up, and were to grab the posterior part of your humerus at the glenohumeral joint and basically just slide your humerus anteriorly, so do a posterior to anterior glide, what would ultimately stop me there and keep me from entirely dislocating your joint are those static stabilizers. So I would hit, basically fully stretch out the joint capsule, as well as, in that case, primarily the middle glenohumeral ligament, and that's going to keep me from sliding your humeral head off of your glenoid. So your static stabilizers limit end range of motion. They limit one bone from sliding off another. As opposed to your dynamic stabilizers, well, those are your muscles. So that's where it says contractile. Contractile tissue is your muscles. They contract, they shorten. So your dynamic stabilizers are responsible for assuring stability of the joint in the middle of the range of motion, not at the extremes. So in the case of the shoulder, your dynamic stabilizers include the muscles of the rotator cuff, and then the long head of biceps tendon is going to be your other dynamic stabilizer. So let's look at each of those then on the anatomy app. Pull this guy up. So in terms of the static stabilizers, we'll start here because that's already up there. So you've got the joint capsule itself. So as you can see there, because it popped up, so that's the fibrous membrane of the glenohumeral joint. So again, that's that most superficial layer of the joint capsule. Lots of really dense collagen, and it keeps those two bones aligned with each other. So the joint capsule is a primary static stabilizer. In addition to, take off the capsule, then we've got the glenohumeral ligament. So you've got three of those. There's a superior glenohumeral ligament, and the superior glenohumeral ligament is primarily going to limit inferior slide. And so what that means then is it keeps your humerus from sliding below the glenoid cavity. So if somebody just pulls your arm straight down, that's an inferior glide, and so that motion is primarily limited by this superior glenohumeral ligament. In addition to that, there's another ligament that I got to put back on. Whoops, too far. This ligament here, the coracohumeral ligament, to some extent also limits that inferior slide. Going back. Then we've got our middle glenohumeral ligament. And so the middle glenohumeral ligament primarily limits external rotation, so it keeps you from rotating the humerus away from the midline. And then we've got our inferior glenohumeral ligament down here. And so that is going to limit abduction and external rotation. And then if I spin them around, there's also a posterior band to the inferior glenohumeral ligament. So this, apparently the anatomy app doesn't separate them out, but there's two bands. There's an anterior band and a posterior band. And so the posterior band is here. So the posterior band of the inferior glenohumeral ligament limits posterior translation or posterior sliding of the humeral head, keeps it from moving behind the glenoid. So it's injured in a posterior glenohumeral dislocation. So typically what happens there is somebody falls. So, like a football player or, somebody in a contact sport, their glenohumeral joint is in flexion, their arm straight forward, and then their glenohumeral joint is also in internal rotation. And so they kind of fall and catch themselves in that position. And so sometimes with enough force, that'll push the humeral head off of the glenoid posteriorly. So that's a pretty uncommon shoulder dislocation. I think those only account for like 10 to 15% of shoulder dislocations. The much more common ones are your anterior dislocations. So those are our static stabilizers. So again, the joint capsule, the superior, middle, and inferior glenohumeral ligaments, and then the coracohumeral ligament as well. And so in addition to those, we've got our dynamic stabilizers. So I'm going to use the slideshow because life's easier than messing with all the muscle layers. So what you're looking at here, you're looking at the glenoid, obviously. So the glenoid is here. And then, so obviously the right side is the anterior part of the diagram, the left side is the posterior part. And so we've got our rotator cuff muscles you can see here. So here's supraspinatus on top of the joint, infraspinatus back here, teres minor, inferior to infraspinatus, and then on the front, or on the anterior aspect, you've got subscapularis. And so those muscles obviously run pretty close to the joint capsule, and so those are our primary dynamic stabilizers. They if they're functioning correctly, keep normal alignment between the humeral head and the glenoid and help stabilize the shoulder as well. So in addition to those, there's also the long head of biceps tendon. Our biceps has two heads, long head and short head, and so the long head originates up here. I'm kind of mousing over it, and it runs, it originates from the supraglenoid tubercle, a little bump that's up here on the top of the glenoid cavity. The only thing I haven't talked about yet is the labrum. So the glenoid labrum is a ring of fibrocartilage, and I'll go back to the anatomy app and I'm going to pull his arm off. So we'll make his arm disappear, make his humerus disappear. That go away. We're going to make this little synovial sheath go away. And then we're going to zoom in. All right, so now we're looking inside the capsule, in at the glenoid. I click on this little guy. That is his glenoid labrum, as you can see. And so what the glenoid labrum is a ring of fibrocartilage. So fibrocartilage is the type of cartilage that makes up the discs in your spine. So since we're on here, these little guys, that outer portion of this, or most superficial portion of this, is also fibrocartilage. So fibrocartilage is really good at absorbing impact. In the case of the glenohumeral joint, or the glenoid labrum, one of the ways to think about it is kind of like having a rubber band atop the glenoid. So that does help cushion impact a little bit, but it allows for a little bit more overlap between the humeral head and the glenoid cavity, so it ensures some stability. And in addition to that, there are some proprioceptors, which are position sensors, if you will, in the labrum as well, so they help you be more aware of where the joint is in space. And an important thing to know about the glenoid labrum is that the long head of biceps tendon actually runs in with it. So if you get damage to the long head of biceps tendon, you'll also then sometimes get damage to the glenoid labrum as well. So oftentimes, somebody like baseball pitchers will have a biceps injury as well as an injury to the labrum. So they'll have a labral tear and biceps injury that go together because of that interconnectedness between the long head tendon and the labrum. All right, so that's our glenohumeral joint. All right, so I got two more case studies that we're going to cover, and then we're going to call it a day. So the first is a baseball pitcher with shoulder pain. And so we'll pretend you're an athletic trainer, physical therapist, orthopedist, whatever you want to be. But you've got a college baseball pitcher that comes to you complaining of shoulder pain. And so if you ask him, where does it hurt? When does it hurt? All that kind of stuff. He's going to tell you that he has pain on the posterior aspects, on the back of his shoulder, that kind of radiates a little bit up into the top of his shoulder, but it's mostly on the back. And you would probably then ask him, well, how long has this been going on? Or do you remember any specific injury or anything like that? So we're going to pretend that it's April. and that he's had this pain since February. So it's late in the college baseball season, and he's had this pain since fairly early in the baseball season. And then it's gotten progressively worse. So the pain, whereas before it'd be like a 1 or a 2 on a 10-point scale, now sometimes it's up, around a 5 or 6. So it's pretty painful. And in addition to that, as the pain has gotten progressively worse, he's noticed that he's lost velocity on his pitches, so they're slowing down, can't throw quite as hard, and he's also lost control of his pitches. He also tells you that sometimes it feels like his shoulder gives out or slips a little bit, especially when he's in this position at the end of the windup during a pitch. Or technically this is called the cocking phase. So when he's in full external rotation of the shoulder, sometimes the shoulder feels like it slips a little bit, and so then that slip causes pain, but also instability or a feeling of instability, which then affects both the trajectory and the velocity of his pitch. So what could be going on here? Well, what he's actually got is posterior impingement of the shoulder. We'll talk about a couple different types of impingement, only one today. And so what he's got going on is posterior impingement. So what's happening is that he's getting a pinching of the supraspinatus and infraspinatus muscle bellies between the humerus and the glenoid, specifically between the greater tubercle of the humerus and the glenoid. So one of the things that I would point out here or ask you here is, can you do this with your shoulder? Do you have this much external rotation range of motion? And unless you're a pitcher, javelin thrower, some kind of throwing athlete, you're probably not anywhere close to this. I know that I'm not. And so the follow-up question I have for you is, okay, well, how can he do this? How is his shoulder different from yours? And there are several reasons for that. The first deals with the bone structure itself. So as a big league pitcher, he has probably been throwing since he was, let's say, 6 years old. Most kids that play baseball start fairly young. So he's been throwing certainly since before he reached skeletal maturity. That means skeletal maturity is when your bones stop growing. For most people, it's in their early 20s. So we're going to say he probably started throwing a baseball somewhere around the age of 6 and has probably continued. He's, I assume, played other sports, but for the most part, he's thrown pretty much continuously since he was a fairly small kid. And so in the humerus, you have a growth plate that runs kind of in through here near the anatomical neck. And so when you throw a bunch before you reach skeletal maturity, that actually changes the orientation between the humeral head and the rest of the humerus. And it'll actually cause the humerus to rotate laterally a little bit. So his humerus is rotated externally a little bit from that repetitive throwing motion. It's actually kind of twisted his humerus externally or laterally. So that's one thing. And then the other thing is with that repetitive throwing, there's a growth plate in the scapula as well, near the glenoid, that growth plate is actually going to, it'll change in response to that repetitive throwing, and it'll cause the glenoid to face posteriorly a little bit. It'll tilt the glenoid slightly posteriorly. And so both of those things, that external rotation in the humerus or the shaft of the humerus relative to the head, and that slight posterior tilt or rotation of the glenoid cavity allow for him to have that really extreme external rotation range of motion. So in addition to his bones being slightly differently shaped than yours or mine on his throwing side, his right side, because he's a left-handed pitcher, his right side is about like the rest of us. His left side is going to be different. In addition to different bone structure, he's also going to have increased laxity or stretchiness, if you will, or not stretchiness, looseness, increased laxity or looseness of his middle glenohumeral ligament, as well as the anterior band of his inferior glenohumeral ligament. Again, those two are your primary resistors of external rotation. If you repeatedly, forcefully externally rotate the shoulder, you're going to stretch those ligaments out. And so since he stretched those out, he has some extra looseness there, and he's able to reach this extreme of external rotation. But before I get into that, the reason that's good is because for a pitcher, the longer you can be in contact with the ball, so the bigger your arc of motion here, the more force or more time you have to impart force on the ball. So that's an important part of increased velocity, is this concept that you'll talk about in biomechanics called impulse. The longer period that you can apply force to an object, the more force you can apply to it, so then the faster you can throw the ball. So by having this really extreme external rotation range of motion, he can apply force to the ball over a longer arc of motion, so he can throw the ball faster. Now, as a consequence of that, though, typically they're going to have tightness of their posterior capsule. And so what happens there is that it pulls the humerus slightly up, so slightly superiorly, and then also slightly posteriorly. And so then, because of that orientation where the humerus, switch to the anatomy guy, this will help a little bit. If we put his arm back on him, see if I can do that. Undo, undo. Oh, there we go. Now we're getting closer. So if we, there we go. And I'm going to hide this tendon sheath again. Actually, we'll just turn off the connective tissue. Make life a little easier. All right. So looking at him normally, so you can see, remember that this is the greater tubercle. And so if we abduct the arm, if we bring it out to the side, then the humeral head is going to slide down. Okay. And so at a really extreme of flexion, you can get some, or sorry, abduction, really extreme of abduction, you can get some bumping between the greater tubercle and the glenoid. And so especially with both abduction, external rotation, and a posteriorly tilted glenoid, you can get some impact there between, again, that greater tubercle and the glenoid. And so in the process, oops, let me see if I can add some muscles. And it doesn't matter. So your supraspinatus would be here, your infraspinatus would be here, and basically as the greater tubercle bumps up against the glenoid back here in the extreme of abduction, external rotation, you're going to pinch the infraspinatus muscle and the supraspinatus muscle between those two structures, and so that's going to cause pain. And that's what's being impinged posteriorly are those two structures, and they're going to get pinched back here, and so then that causes the pain, the loss of velocity, and all that kind of stuff. So typically, if someone has that condition, which is the second most common type of impingement, and I think it's the most common type in throwing athletes, usually what we end up doing is a bunch of internal rotation stretches, trying to get that range of motion back and trying to get the humeral head seated more normally on the glenoid. So there you go. So he's got posterior impingement. All right, and our last one. So quarterback with a shoulder injury. So just tell you a true story. Years ago now, I was working as an athletic trainer, contract athletic trainer, and I was covering middle school football, which is as fun as you can imagine. So I'm covering middle school football, and the quarterback for our team drops back to pass for one of our 2 passes per game. The quarterback drops back to pass. He's holding the ball up like Davis Webb is here in this picture, and he gets sacked from behind. And so as he gets sacked from behind, he lands on his face. He doesn't catch himself very effectively. And so he actually rotates the ball a little bit to where the end of the ball ends up making contact with the ground first. So this end of the ball here made contact with the ground first. And to his credit, this quarterback had just an iron grip on the ball. And so ball hits the ground, and then he hears and feels a pop in his shoulder, and he's got sudden pain and all that. And when he comes running off the field, he's holding his arm at his side. It's slightly abducted, slightly externally rotated, and he's not moving his right arm at all. And so he comes over to the sideline, and he's like, my shoulder hurts. And so I said, okay, well, what happened? He's like, the guy, tackled me, and it popped, and now I can't move it, and my shoulder hurts really bad, and he is very much in distress. So ask him what type of pain he's got. He's got, really sharp pain in his shoulder, but in addition to that, he's got some tingling and numbness into his fingers. So, and we get him on the sideline, take his shoulder pads off. Again, he's going to need help, but we get his shoulder pads off, get his shirt off, and get a good look at his shoulder. His shoulder looks like this kid. And so what you'll notice is that his acromion is really prominent, and that he's got a flattened deltoid. So you see over here, his deltoid's got a nice normal curve to it. On the injured side, that normal curve has gone away, and again, you've got this really obvious acromion. But what's happened? And the answer to what's happened is that he has an anterior shoulder dislocation, the most common type of dislocation of the shoulder. And usually the mechanism of injury is what I was describing to you, where it's a combination of abduction, so arms out to the side, and external rotation, which is exactly what that picture was doing on the last slide. So if people get forced into abduction, external rotation, what that can do then is that can rotate the humeral head off of the glenoid. And so typically when it rotates off, it goes anteriorly and inferiorly, so forward and down. And so if this kid would let you, you could palpate or feel up in his armpit and axilla. You can palpate up in his axilla and you'd be able to find the humeral head there most of the time. It becomes pretty prominent. because it's basically sitting there in his armpit rather than on top of the glenoid like it should be. So this is an x-ray, obviously, of an anterior dislocation. So again, most common type of shoulder dislocation, typically the ligaments or the structures injured, again, primarily that middle glenohumeral ligament, as well as the anterior band of the inferior glenohumeral ligament, and then potentially that superior glenohumeral ligament as well. Because again, remember, the superior glenohumeral ligament limits inferior motion, and so if your humerus slides inferiorly and anteriorly, you can injure that one as well. So potentially he has ruptured, but certainly at least sprained or stretched out all three of those glenohumeral ligaments. So there's some damage to the joint capsules or joint capsule as well as the glenohumeral ligaments. And in addition to that, so oftentimes with shoulder dislocations, so one of the common sayings around sports medicine is once a dislocation, always a dislocation. And the reason, or one of the reasons for that, is once you've stretched out a ligament or a joint capsule, it stays stretched out, right? Because they're non-contractile tissues. So once they're lengthened, they stay lengthened unless you have some sort of surgical intervention. So now the joint capsule is extra lax, it's extra loose. Again, you've stretched out your glenohumeral joints. But in addition to just loosening the joint capsule and spraining the ligaments, there are some other fairly common complications that occur with shoulder dislocations. So the first one on here, the Bankart lesion, what ends up happening is as the humeral head rolls anteriorly and inferiorly, the muscles of the shoulder are going to be contracting. They're going to be trying to stabilize the shoulder joint, but the force is too much. And so if the rotator cuff is contracting, what it actually does is pulls the humeral head against the glenoid, which is important. But if the rotator cuff muscles are doing that while the humeral head is rolling off of the glenoid, that can actually cause an indentation here on the anterior and inferior aspect of the glenoid. And so that's called a Bankart lesion. It's a denting, if you will, of the anterior-inferior glenoid. Another really common lesion is called a Hill-Sachs lesion. So a Hill-Sachs lesion is what you can see here. It's an indentation of the humeral head. It actually changes the shape of the humeral head. So same concept, as those rotator cuff muscles are contracting, you're forcing the humerus up against the glenoid. And so in this case, you get a denting, or more technically, a depression fracture of the humeral head. And so those are seen in as many as 80% of first-time shoulder dislocations and 100% of people with recurrent dislocations. So if somebody their shoulder dislocates pretty consistently, they probably have a lesion or an indentation on their humeral head that looks like this. Because what ends up happening is once they get to a certain point in the range of motion where they're abducted, externally rotated, that indentation actually catches on the glenoid and sort of levers it off of the glenoid. So it sort of forces that dislocation. So again, with football season coming up, you'll see guys that have these really big neoprene sleeves on one arm or the other. And then those sleeves actually go inside the shoulder pad, and typically they tie into the laces on the front of the shoulder pad. What those do is they limit abduction, external rotation, range of motion. They try to keep that player from putting his shoulder in a position where this lesion could lever the humeral head off of the glenoid. So in addition to those injuries, you can also, again, because the biceps long head tendon originates there at the top of the glenoid, sometimes you'll get a rupture of it, or it'll pull away from the labrum. Transverse humeral ligament is, I'll show you where that one is on the anatomy guy. So we'll spin it this way. So remember that the long head of biceps originates up here, runs here in the intertubercular or bicipital groove. And if we, let's do with the connective tissue. There's synovial sheath. See if we can, there it is. So that's the intertubercular ligament, or transverse humeral ligament, sorry. So that's the transverse humeral ligament. And so what that does is that holds biceps, the long head, in that groove. And so if you rupture that ligament, now when they internally, externally rotate, the biceps tendon will actually click back and forth outside of that groove. And as you can imagine, that causes pain, particularly for a throwing athlete, is really problematic. You've also got rotator cuff strain, so you can stretch out the rotator cuff muscles, potentially rupture them. The axillary nerve supplies the deltoid and the teres minor muscles, and it also gives skin sensation for essentially your lateral deltoid area and kind of that middle part of your upper arm, and so they may lose some sensation there as well. So somebody dislocates their shoulder, oftentimes people are like, you just put it back and then they're good. But there are a lot of complications that go with it, and you tend to have an unstable shoulder. And so one of the things that people do or spend a lot of time doing after a shoulder dislocation is actually doing a lot of rotator cuff work. So you see people doing like internal, external rotation with bands, trying to strengthen the rotator cuff to try to, in that case, to try to stabilize the shoulder a little bit. All right, so we'll get to this stuff, to scapulohumeral rhythm, next time. So thanks for sitting through all of that, and hopefully some of that was interesting and or helpful for you. So we'll see you next time.